Thank you so much. And to all of you who have joined us for today's webinar, welcome. This webinar is co-sponsored by the American Hospital Association's Section for Psychiatric and Substance Abuse Services, as well as AHA's Physician Alliance. And it's entitled Advancing the Care of Patients with Opioid Use Disorder in Outpatient and Emergency Settings. Today, you're going to learn how one program engages multiple patients at multiple points of care through an in-house addiction team and clinic, all working in coordination with emergency department staff. It's my honor to be joined, and this is Rebecca Chicky of the American Hospital Association, to be joined today with Sarah Wakeman, M.D. She is the Medical Director of the Substance Use Disorders Initiative and Program Director of Mass General Hospital, as well as Assistant Professor of Medicine at Harvard University. Her colleague, Dr. Ali Raja, who also has an M.B.A., is the Executive Vice Chairman of the Department of Emergency Medicine, also at Mass General Hospital, and he also is an Associate Professor at Harvard University. Today, what they are going to do is highlight how they are transforming the care for the chronic disease of opioid use disorder and simultaneously improving quality, accessibility, and the clinical outcomes, and ultimately enhancing the value of treatment for patients suffering with this illness. So, two housekeeping matters before I turn this over to Dr. Wakeman. First of all, we will allow time for Q&A at the end of the webinar. Please note that there is a chat box. We will not be taking questions from any of you who may have dialed in on the phone, but direct you to your ability to ask questions online. If you think of a question while throughout the webinar, please go ahead and submit it, but we will hold those until the end. I'll be looking through the questions, and if there are several that are very similar of nature, like how do you fund this, I'll aggregate all those questions so that everyone can benefit from it, but so our speakers can address it in one-stop shopping mode. So with that, Dr. Sarah Wakeman, please proceed.
Great. Thank you so much. Thanks for having us, and thanks everyone for joining today. And I look forward to the discussion at the end. My only disclosure is I'm doing some research with Optum Labs using their claims data to evaluate the impact of different types of treatment for opioid use disorder. So why are we having this webinar today? Why are you all joining in? Well, I imagine, given your interest, that you're well aware that we're in the midst of a public health crisis. And in fact, drug overdose is now the #1 cause of death for all Americans under age 50. More people have died from overdose than from the peak number of deaths from car accidents, from HIV, or from gun deaths. So when you hear people use terms like epidemic or crisis, the reason for that sort of terminology is really the scale of what's going on. It's been so dramatic, in fact, that it's actually affected U.S. life expectancy with a 3-year decline, the first since the early turn of the century in the Spanish influenza epidemic. There's been a lot of focus, particularly in hospitals and healthcare systems, and legislative action around prescribing of opioids. I'm sure you're all well familiar with that at this point. And the reason for that is really when you look at the onset of the current crisis, it was correlated with changes in opioid prescribing, which has now been well discussed and documented, and with many lawsuits ongoing around the roots of the current epidemic. And we saw that as changes in prescribing practices occurred and there were increased sales of opioid pain relievers, that in parallel there's a rising rate of deaths due to prescription opioids and treatment admissions for opioid use disorder. But it's important to note that what started the epidemic and what's sustaining the epidemic are not the same thing. And if you look at deaths due to natural and semi-synthetic opioids or opioid pain relievers, you can see that those deaths really peaked around 2011 and have been declining most years since. And yet, rather than seeing lives saved, what we have seen is actually an uptick in the rapidity of the overdose rate and death due to opioid-related overdoses, as we saw first rising rates of death due to heroin, and then now, in the current era, rising rates of death due to illicitly manufactured fentanyl, and that's this dark blue line here. And I think that gets at the nuances of the crisis and the real urgency to think about how to address this crisis within the healthcare system. that if all we do is focus on the supply side of the equation as sort of making prescription opioids harder to access, in fact what we see is that people die at faster rates, that we may in fact be moving up the rate of death and the speed of death that's occurring, because you take people that are using prescription opioids, and rather than addressing the underlying opioid use disorder, they shift into the illicit drug supply, which is increasingly poisoned with illicitly manufactured fentanyl. And so instead, we need to also be thinking really intensely about how do we address the demand side of the equation? How do we treat opioid use disorder? And how do we help people who are using opioids stay safe and not die from overdose? One of the challenges that we're up against is that when we think about the healthcare system and public health, it often takes years to see clinically significant and meaningful change. It's hard to create change in the systems that we live and work in. And yet the drug overdose crisis is changing rapidly, and much more rapidly than our ability to get our arms around it. In 2017, we saw changes evolve as well. So we continued to see the overdose death rate increase by about 10%. And opioids continued to be the main driver. They were involved in over 2/3 of overdose deaths. And as I mentioned, that's been predominantly driven now in this third wave of the opioid overdose crisis by illicitly manufactured fentanyl, with heroin and prescription opioid-related deaths remaining stable. But as we see sort of attention focus on the opioid crisis, we can't only pay attention to opioids, because we're beginning to see rates of overdose deaths from cocaine and stimulants increase. And in 2017, they increased by 34% and 33% respectively. And so most people are now talking about this as a drug overdose crisis, not as an opioid crisis. And although much of the media attention and sort of lay press recognition of this crisis, and arguably the reason why we're seeing more of a public health focus in the current crisis instead of a criminal justice focus, has been the image that this is an issue that's really affecting non-Hispanic white people across the country. And yet, like in much of healthcare, racial disparities and institutional racism is a huge issue when we think about drug use and addiction treatment outcomes and overdose as well. And in 2017, the largest relative change in overdose death occurred amongst Black Americans, with an increase of 25% in terms of death. We often hear the statement that addiction doesn't discriminate, and while we could argue a little bit about that, the sentiment there really is that anyone can be at risk of developing a substance use disorder. I would argue, though, that overdose does discriminate. When we look at who's most likely to die from an opioid-related overdose, those at greatest risk of death are often the most marginalized from healthcare and from the systems that we do have designed to serve people who use drugs. Based on data that's been done in Massachusetts, where we're fortunate to have a very unique data set that links a number of different pieces of data to create sort of a rich picture of who individuals are who experience both non-fatal and fatal overdoses. We've learned that people are much more likely to die if they are experiencing homelessness. So the opioid death rate is 16 to 30 times higher for individuals experiencing homelessness, and it's more than 120 times higher for individuals with a history of incarceration. Other populations that are at higher risk of dying are people who have serious mental illness and pregnant and parenting women. And so when you think about these vulnerable patient populations, people who've recently been incarcerated, who have unstable housing, who have serious mental illness, who are pregnant or parenting, they're often the individuals who are least likely to be served by the existing addiction treatment system. Our treatment models are simply not designed with these very marginalized patient populations in mind. When we think about how to begin to address that demand side of the equation, how do we address opioid use disorder, how do we treat it effectively, and how do we keep people from dying? We're fortunate to have a ton of science and a ton of research and evidence to support us in thinking about what are the most effective interventions and where should we tailor our approaches. This was a powerful special report in the New England Journal of Medicine, co-authored by Nora Volkow, the head of the National Institute of Drug Addiction, and Francis Collins, the head of the NIH. And they highlight that when you think about any public health crisis, be it Ebola or HIV, it's really been science that's been our strongest ally in resolving these public health crises. And ending the opioid overdose crisis will not be any different. However, when we think about how we as a society and we as a healthcare system treat people who use drugs and people with addiction, it has not been science that's guided our care. For the most part, it's unfortunately been stereotype and stigma and a lot of misinformation that has really guided the way we treat and think about and care for people who use drugs. This is a quote by Dr. Dole. Dr. Dole was a physician scientist who's an endocrinologist by training, and he was one of the two scientists who discovered methadone as a treatment for opioid use disorder. And he really stumbled into the field of addiction medicine, not coming into it with the same sort of preconceived notions that many of us as members of society have. And this is an interview reflecting on his career where he highlights that the most educational experience for him in his 30 years of working in the field was to learn that those sort of notions that he brought with him, the idea that people with addiction are weak or hedonistic, unreliable, dangerous, is totally false. And yet those myths, that image of who it is, the person who uses drugs or injects drugs or the person with addiction, continues to be believed by the majority of the medical profession and the public, and that distorts our policy and unfortunately distorts our health care as well. So what do we know about addiction? Well, addiction is defined as a primary chronic disease that's characterized by compulsively using drugs despite bad things happening to you. And there's a couple important points in there. So first, for most people, this is a chronic illness, meaning the goal is not cure, but rather to get people engaged in treatment and to hopefully get them into remission and minimize the cycles of active illness or recurrence. But perhaps the most important thing to understand about addiction is that the hallmark of the illness, the defining characteristic, is compulsively using drugs despite bad consequences. And the reason why that's so important is that it can be so challenging for those of us who love someone with addiction, who take care of people with addiction, and for the public to understand when they're looking at someone in the throes of active addiction, that that inability to stop, because it's very tempting to look at someone who's actively using and who's suffering terrible consequences. They may have lost their children. They may be in our emergency room for the 20th time with some medical consequence of ongoing untreated addiction. And it's very tempting to look at them and to think, why don't they just stop doing this thing that's so clearly leading to all of these bad things happening to them? And yet the defining hallmark of the illness is not being able to stop despite bad consequences. The other reason that matters is that when we think about our societal approach towards people with addiction, we spent about 100 years trying to punish people into getting well. We have a system that sends people to prison for positive toxicology or for ongoing drug use. We take people's housing away. We take their children away. We take their jobs away. We kick them out of their homes and their environment. We have a very punitive system that is based on a lot of myth and common sort of notions that people have to hit rock bottom or that more bad things have to happen to them. And yet again, it's a defining hallmark of the illness is not being able to stop despite bad things happening to you. And if we know that using drugs is an incredibly powerful coping mechanism in times of stress, building a system that tries to punish people into getting well is a really ineffective way to address this illness. So if we think about opioid use disorder in particular and the natural history of opioid use disorder, this is a homemade graph you'll be surprised to hear. Early on when people use opioids, they go from feeling normal to feeling euphoric or feeling high in someone who's vulnerable to developing an opioid use disorder. And whatever that first exposure is, whether it's through medical route, whether it's through experimentation or non-prescribed opioid use, people go from, again, feeling normal to feeling sort of super normal. It's important to note that opioids don't make everyone feel euphoric and good. Some people feel dysphoric and nauseous and itchy, and I'm sure we've all had patients where we've seen that reaction, and those individuals are probably protected from developing an opioid use disorder. And yet if you talk to someone who has an opioid use disorder and ask them about their first experiences using opioids, often patients will describe almost magical terminology about that first exposure, that it felt like falling in love, or the first time they felt normal or right. Really sort of, I think, giving a personal description to the difference probably at the receptor level in people who are vulnerable to developing this illness. But what we see is a transition from using to feel good to needing to use to feel normal and then needing to use just to not get sick. And so someone with ongoing severe opioid use disorder is generally not getting high anymore. They're spending most of their day just trying to feel well again, just trying to feel normal, and they get caught in that terrible cycle. And so the goal of medications in particular for opioid use disorder treatment is to get people back to that normal. So if you think about that cycle of being caught down here where you spend your whole day, again, just trying to feel well and just trying to not be sick, we have medications that essentially restore normal functioning. And so as an internist and addiction medicine doctor, there are parallels in how we treat opioid use disorder with many other medical conditions. So if you think, for example, of insulin-dependent diabetes or adrenal insufficiency or hypothyroidism, we have a lot of conditions where our goal is to really restore normal homeostasis, and we do that with medication treatments, often with chemically similar compounds that allow someone to function normally. So medication treatments for addiction and for opioid use disorder specifically have really four main goals. So the first goal of opioid use disorder is to relieve withdrawal symptoms. Although we all learn in medical school that you can't die from opioid withdrawal, that's not entirely true. People do die from opioid withdrawal. They tend to be people who are detained in jail and are not receiving treatment for the symptoms of opioid withdrawal. But it both can be fatal and, even more importantly, it's incredibly painful and causes tremendous suffering. And people will go to, will do a lot to try to avoid the pain of withdrawal, and that's often what keeps people trapped in the cycle of using early on. But if all we do is relieve withdrawal symptoms, the vast majority of people go back to using opioids. So simply treating withdrawal or medically managing withdrawal is not enough. The long-term goal of these medications is first to block the effects of other opioids, because again, we know that recurrence of use will happen. That's a part of a chronic illness. But if someone's taken their medication and they don't feel the euphoric effects of that intercurrent opioid use, then that's really a preventative mechanism that first prevents them from dying from an overdose, but also reinforces their recovery and reinforces their reasons for maintaining abstinence. And then over time, these medications reduce cravings, which is a strong psychological urge to want to continue to use, and which is one thing that drives people back to use even after withdrawal has been managed. And then also to restore normal function and to restore the normal reward pathway in the brain, and that's really the long-term goal of medication treatment. So as we think about other health conditions and other chronic diseases, the opioid use disorder actually maps very closely onto how we think about treating an illness like diabetes or HIV, where again, because this is a chronic illness, the goal is not cure, but rather to prevent acute and chronic complications. So the reason we care about what someone's A1C is when they have diabetes is not because there's any particular value on any number, but rather because we know that higher levels are associated with bad consequences that we want to prevent. We want to prevent people from losing limb amputation or from developing end-stage renal disease. And similarly, the reason we care whether someone continues to use opioids is not, again, because of any sort of value judgment about drug use, but rather we want to try to prevent acute and chronic complications like overdose or hepatitis C or the social dysfunction that can come in someone's life when they have an opioid use disorder. And then the list of medications is actually, or the list of treatments is actually quite similar. So taking an illness like type 2 diabetes, not everyone needs medication, but everyone should have access to medication, and medication is a cornerstone of treatment for type 2 diabetes. Behavioral support is crucial. It's very hard to manage a chronic illness and to make the lifestyle changes that are necessary to manage many chronic diseases. And then importantly, regular monitoring. So we would never start someone on insulin and then not see them again. We're going to monitor that person very closely up front and then lengthen out our monitoring frequency as that person stabilizes. And the same approach would be true for opioid use disorder, where medications are a backbone of treatment, behavioral support is crucial, and then ongoing regular monitoring is necessary. The great news when we think about opioid use disorder, as opposed to the early years of, for example, the HIV crisis, where we really had no treatments and had to wait for science to catch up and to develop new medications and new technologies. With opioid use disorder, we have life-saving medication that broad access to these medications could fundamentally alter the overdose epidemic. This is a study published in 2006 looking at the country of France, where there's no special license required to prescribe buprenorphine the way that we regulate buprenorphine in this country. And they were able, you can see in the gray here, the number of patients treated with buprenorphine. They were able to get about 90,000 patients treated in less than a decade, and they saw a 79% decrease in heroin overdose. So dramatic impact. When we look at observational studies of these medication treatments, they are fundamentally life-saving. And when we think about the scale of the death toll right now, it could really alter what's going on across our country. There have been decades of studies. I'll show you a little bit of the data looking at medication treatments, particularly on mortality. So this is a large meta-analysis published in the BMJ in 2017 that looked at the mortality rate in and out of treatment, both for methadone and buprenorphine. What I'm showing you here is just for buprenorphine, which is one of the 3 FDA-approved medications to treat opioid use disorder. And they show that when people are engaged in treatment, their risk of dying both from overdose and their all-cause mortality is decreased dramatically. And yet when treatment stops prematurely, deaths increase. We know that medication treatment improves not just survival, but also retention and abstinence. This is a small study that was published early on, 2003, right when buprenorphine was first becoming available, but it was dramatic in its findings. It took individuals that were in an inpatient treatment setting who had heroin addiction and randomized them to either buprenorphine maintenance, so being started on buprenorphine with psychosocial counseling and continued for a year, or medically supervised withdrawal, which is colloquially referred to as detoxification, plus intensive psychosocial treatment. And what they found was that the group that got medically supervised withdrawal and intensive counseling, no one was retained in treatment, and 20% were dead at the end of the study period. And in the buprenorphine maintenance group, 75% were retained in treatment, 75% were totally absent by toxicology, and no one died. So pretty dramatic differences. I think if we had another intervention for an illness that resulted in no one getting well and 20% of participants dying, we probably would not continue to offer it. And yet still, people refer to medically supervised withdrawal or detox as an effective treatment for opioid use disorder despite the lack of evidence. We also know that treatment retention is much higher with ongoing maintenance. So you saw one of the early taper studies of buprenorphine. There have been a number of studies looking at longer, slower tapers of medication. So the idea early on was, well, maybe it's that we can't do medically supervised withdrawal for a week. People need a longer, slower taper. This was a paper published in JAMA looking at a 180-day methadone taper that was psychosocially enriched with counseling compared to methadone maintenance, being put on the medication and kept on the medication. And you can see that right away the survival curves start separating. So the solid line are people on the 180-day taper. And by the time that taper is over, the vast majority have fallen out of care. In contrast, people are put on medication maintenance and continue out to a year. Roughly 70 or 80% of people were still retained in treatment in this study. So really dramatic differences. And then at the study end date, when the medication stopped, people fell out of care. The other thing to note is that this is actually a good prognosis disease. I think often when we talk about opioid use disorder or heroin addiction, the first word that comes to mind is not hope for most people, and yet that's what I think, because this is actually very treatable, and most people will get well if they get effective ongoing access to good treatment. This is one of the longer-term studies we have of buprenorphine, published by Dr. Weiss and colleagues. It was a multi-site clinical trial looking at treatment of prescription opioid use disorder with buprenorphine treatment. And they followed half of the cohort for out to 42 months. And they found that at the end of 42 months, only 7.8% of people met criteria for current opioid use disorder by DSM-IV criteria. So 92% of people no longer met criteria for opioid use disorder. That's incredibly promising. 92% of people in remission when we think about this illness that's killing so many people each year. And yet, despite the fact that we have medication and treatments that we know work, we also know that most people never have access to these treatments, and when they do, they stay in care for far too short of a period of time. This was a study looking at people who survived an overdose here in Massachusetts, so people after a non-fatal overdose, and looked at what percentage of those individuals received medication treatment and how long were they treated for, and then what was the impact on mortality. And Dr. LaRochelle and his colleagues found that even this cohort of people who just survived an almost fatal event, only 11% of people received methadone for a median of 5 months, 17% received buprenorphine for a median of 4 months, and 6% received naltrexone for only 1 month. And yet, despite the short duration of treatment, there actually was a reduction in all-cause mortality for methadone and buprenorphine. That was not seen with naltrexone. There was no mortality benefit. And this is very similar to other studies, which have shown that methadone and buprenorphine are life-saving medications. There's a mortality benefit even from short bursts of treatment, but that in general, based on what we know from clinical trials, people are simply not getting to the duration of treatment we know is necessary to sustain long-term remission. And I think that gets to how we built our addiction treatment system, where in essence, much of our addiction treatment system is a high threshold, high barrier system that's very challenging to access. We make it really tough for people to get into care. They have to know how to navigate the system. They have to be able to call and get on waiting lists and call back and show up on time and be polite in the lobby and wait to be seen and complete an intake. A lot of steps for someone who's living in chaos and dealing with a daily fatal condition and the risks that go along with that. And so if we think about sort of high threshold versus what I'll call low threshold care, and we think about a person who's actively using drugs and the barriers that they face to engage in services. So the first is what one study called the registration threshold, so that those steps I just walked through to simply be able to access care. So to figure out what program they can go to, does it take their insurance, do they have insurance, when do they show up, how long is the waiting list, all of those multiple steps that many people simply never even get across that threshold. Even when people cross that initial registration threshold, they then have to overcome what's called the competence threshold, the ability to actually communicate their needs to their treatment team, which is tough for many people, but it's a tall order for a population of patients who generally have been treated really poorly in the healthcare system. For many people, their experience of coming into the healthcare system is not one where they feel that they can trust their care team and share honestly what's going on. And so that concept of trust really is folded throughout these barriers and thresholds. And then the last one that I love the description of is what was called the efficiency threshold in this paper. And so one person who worked in a lower threshold system said, what about that person who needs 1,000 cups of coffee before they're able to start speaking about their needs? So that person is never going to be served by the addiction treatment system the way it's traditionally been designed. And so this new model of lower threshold care really aims to reduce these barriers or thresholds by having less stringent eligibility criteria and to really focus on access and engagement for people who most need treatment. We think about our healthcare system, it also has not been a system that generally welcomes in people who use drugs or people who are at highest risk of dying. And yet we often blame patients that rather than thinking about the system's failures that are inherent in the way this care model is designed. If you sort of think of a somewhat ludicrous example of what it would look like if we treated people with heart disease the way we treat people who use drugs, imagine if a person was admitted to the hospital with a heart attack and was told explicitly that it's her fault because of her diet or her high-stress job or history of tobacco use. Because she caused this condition, she's told that she can find treatment on her own and given a list of cardiologists and cath labs to call. She's told she can't get life-saving medication unless she sees a nutritionist and loses weight first. And then she's sent home with a stern reminder not to have another heart attack. So obviously this would be ridiculous if we treated anyone with heart disease this way, and it would be malpractice. And yet, unfortunately, this is the way people who use drugs are treated all the time. So if you think about a person who's admitted with endocarditis, they're often told that they caused their condition because of their substance use disorder. If they're lucky, they get a list of treatment programs to call. Sometimes they don't even get that much. Many treatment programs tell people they can't get addiction medication until they see a therapist first. And then I continue to see in discharge summaries from hospitals, notations in the patient instructions of don't use drugs, drugs will kill you, as if that were an effective way to help treat someone with a chronic illness. And yet we know that hospitalization, these moments when people come into our emergency room and they come into our hospital beds, is actually a reachable moment. We have an incredible opportunity to engage with a very high-risk patient population and to initiate treatment that will improve outcomes dramatically. A couple of studies that taught us this early on, both done at Boston Medical Center. The first one looked at all comers to the general medical service, so people who weren't coming in asking for addiction care. And they looked at what would happen if you offered those people methadone. You started methadone in the hospital bed, and then you linked people directly into methadone treatment at the time of discharge. And they found that 82% of that group would follow up for addiction care. So again, non-treatment seeking medically sick population, and yet 82% actually show up if you start them on methadone in the hospital. At BMC, they then did a randomized controlled trial where they randomly assigned, again, all comers to general medical service to either buprenorphine initiation and continuation, so starting on buprenorphine in the hospital and then being linked directly into buprenorphine treatment in the community, versus medically supervised withdrawal, so tapering doses of buprenorphine in the hospital and then a referral to an outpatient treatment program, which is still probably more than many patients get in a hospital setting. And they found that those people that were started and continued on medication, 72% of them would enter into treatment after discharge versus only 12% if they were withdrawn from buprenorphine and then referred to treatment. We also know that treatment can be incredibly effective in primary care, and it can happen really in primary care settings with or without additional services. This is a study done at Yale that looked at primary care management of opioid use disorders. The primary care doctor is prescribing buprenorphine and providing medical management or counseling in the visit with their patient versus medical management plus cognitive behavioral therapy. So seeing someone for sort of what we think of as addiction counseling. And they actually found no difference in opioid use, study completion, or cocaine use between these two arms. So seeing a primary care doc and having a session with your primary care doc, getting that medication prescription was as good as specialized addiction counseling. So it's not to say that counseling is not important or that people shouldn't be offered counseling, but it is to say that we can do this in primary care, that it's incredibly effective, and that we don't need to be requiring that people go elsewhere for treatment. These are just a couple of the papers that have shown what in many cases are somewhat surprising results. They really challenge the status quo of the way we have historically thought about addiction treatment, where we have thought that people need to prove their motivation, that they have to engage in counseling in order to get medication treatment, and many other notions such as those that have led to barriers to offering these services in general medical settings. This sort of body of evidence led me and a colleague to write this article in the New England Journal about the myths and realities of buprenorphine treatment, where we really try to challenge some of the myths that I think are perpetuated by the way we regulate buprenorphine in this country. The myth that, this must be really complicated and dangerous and other chronic disease management given our regulations, when in fact buprenorphine treatment is actually quite simple and certainly more simple than other complex tasks we do regularly like titrating insulin or starting anticoagulation. Many of the stigmatizing notions about medication treatment continue to be a barrier to individuals starting them. This notion that medications like buprenorphine are just replacing one addiction with another, when in fact addiction is defined as compulsively using a drug despite bad things happening to you. So taking a medication as prescribed that allows you to function and feel normal really does not meet the criteria for addiction. And so if we think, sort of pulling all of this together about what an evidence-based checklist might look like for treatment in the acute care setting, so in emergency rooms or in hospitals for people with opioid use disorder, first and foremost, everyone needs to have immediate access to all types of medication for opioid use disorder treatment. It needs to be standard of care that when a person shows up in the emergency room or they show up in an inpatient hospital bed and they have an opioid use disorder, that they are able to access and start all three forms of medication treatment for opioid use disorder. And then thinking about our care systems, much like other illnesses, our focus really is on diagnosing an illness, initiating treatment, stabilizing a person, and then linking people into ongoing care. That's what we do for diabetes, for heart disease, for cancer care, and that really is the model when we think about opioid use disorder treatment as well. And treatment really has to be based on clinical need and the patient's preference and experience. Just like we think about HIV care or diabetes care and tailor it to the needs of the human being in front of us, it can never be a one-size-fits-all approach for opioid use disorder treatment. And then, importantly, overlying all of this is a harm reduction philosophy, that our goal, first and foremost, is to engage with people and to reduce their risk of dying and the negative consequences of their substance use. And that harm reduction is congruent with the principles of treatment, that it's not an either-or proposition. And patient-centeredness also has to be guiding this effort. If we think about the slogan, "Nothing about us without us," which was popularized during the HIV/AIDS era, that concept is as important, if not more important, when we think about designing systems of care to treat people who use drugs and people with addiction. We have to respect the dignity, humanity, and autonomy of the individuals that we're caring for. While our care must be guided by science, and there's robust science, as we've reviewed just briefly, it has to be delivered with compassion. And one way of doing that is using person-first and accurate language that doesn't perpetuate stigma, and by involving affected individuals in the design of systems of care. To that point, one small thing that each of you on the phone can do in your practice is to commit to using non-stigmatizing language. Words matter. This is not an issue of political correctness or semantics. There have been clinical trials that have shown that clinicians are more likely to recommend punitive treatment when they hear a person described as a substance abuser than a person with a substance use disorder. And the language that's historically been used to talk about addiction are words that we would never use for other health conditions. We would never refer to a person with an eating disorder as being a food abuser. We don't talk about people as their disease. We don't say, "I'm going to see the breast cancer in room 34. And so similarly, we should not be using words like alcoholic or addict or the term substance abuse, but rather to use non-stigmatizing, medically appropriate and person-first language like a person with a substance use disorder. Another term to avoid is the term clean or dirty. Although clean may sound like a kind thing to say because you're talking about someone who's in recovery or in remission, it really implies that people who actively use drugs are dirty. A friend and colleague of mine who's in recovery was asked, actually on a job interview, how long he had been clean for. And his response was that he'd been bathing since he was born, so he'd been clean for his entire life. And you can get from that comment that really the implication is that someone with addiction or someone who's using drugs must be dirty, and so avoiding terminology that perpetuates those stigmatizing notions. So I'm going to end here and turn it over to Dr. Raja, but as I've sort of tried to walk you through briefly some of the research and some of the approach that we've begun to embrace here at Mass General. We launched our Substance Use Disorder Initiative in 2014, and that was a system-wide effort now 5 years old, to take all of these principles, all of this evidence and how we treat addiction, and to lower the thresholds and integrate treatment into general medical settings so that it's available where our patients actually show up, and we make it as easy as possible for people to enter into care. In the inpatient hospital, we have a interdisciplinary inpatient addiction consult team that can see people across our 1,000-bed hospital and initiate treatment and link people into care. We have an urgent care low-threshold bridge clinic that essentially removes all barriers to care. It's a walk-in clinic open 7 days a week to stabilize patients who are most marginalized and least able to engage in care. We've integrated recovery coaches or people with lived experience who are in recovery themselves into our care teams. We have, I think, 16 now across the system. We've integrated treatment into our primary care settings with teams of outpatient addiction champions. We've started a perinatal substance use clinic that's a one-stop shop integrated clinic model called our Hope Clinic for pregnant and parenting women, their children, and their families. And then we've launched our Get Waivers campaign to get our buprenorphine, our emergency medicine colleagues waivers to prescribe buprenorphine. And you're going to hear about that in much more detail from Dr. Raja, our Vice Chairman of Emergency Medicine, next. So, Lee, I will turn it over to you now, and then happy to take questions at the end.
Fantastic. Thank you, Dr. Wakeman. I appreciate it. My name is Ali Raja, and I'm an emergency physician here at Mass General. And about 3 years ago, I sat in Dr. Wakeman's office getting basically a very similar, this presentation is very updated with new and cutting-edge data, but a very similar education from Dr. Wakeman because, to be honest, while I've been treating patients with opioid use disorder for many years in the emergency department, I had no idea what the data behind the effective treatment models that she's described here actually were. So she sat me down. She invited me up to her office. She's got a great view. Thank you for inviting me up, Sarah. And she taught me a lot of the stuff that you just learned. And it couldn't happen at a better time because at the same time, our specialty of emergency medicine was starting to recognize the issues with patients with opioid use disorder as well as, not the issues with the patients, but the issues with a lack of treatment available for those patients. And the fact that, you know what, we weren't fixing the problem. So in 2017, the American College of Emergency Physicians put out a poll of emergency physicians around the country asking, hey, we're talking about this. It's all over the news. Are things getting better? And the vast majority of physicians, of emergency physicians who replied said, no, it's not getting better. It's either staying the same or it's getting worse. And that is actually true. So when you look at patients with opioid-related inpatient and emergency department stays in the hospital, the blue line here is inpatient stays to the hospital. Those numbers rose 64% between 2005 and 2014, that 10-year period. But the number of patients presenting to emergency departments, I mean, that rate for inpatient stays, unacceptable and very, very high. But the rate for emergency department stays was even higher, and it led to a real recognition in our specialty that we need to be doing more. The problem was that for most emergency departments in this country, the options they had available to them were limited. The same poll noted that 93% of emergency physicians said that in their emergency department, the only real options are detox and abstinence. And that was all. And that was true here at Mass General. That was true at other hospitals around Boston. That was true in small community hospitals in the middle of the country. The options simply weren't available to them. And so given the data for buprenorphine and other medication-assisted treatment for opioid use disorder, we started looking at this further as a specialty. Dr. Gail D'Onofrio and her team at Yale were one of the first group of emergency physicians, if not the first group, to actually begin trialing this. Their JAMA study, published, I want to say 3 years ago now, looked at a randomized trial of patients who were referred for outpatient care, had a brief intervention in the emergency department for their opioid use disorder, or were begun on buprenorphine. They followed these patients up long term, and the patients who had a continued treatment at 30 days and much longer as well, but here's the chart for 30 days, was much higher in the patients who began buprenorphine. This study was eye-opening and for me, life-changing because of the fact that it took a treatment that had heretofore been used in primary care clinics or in specialized addiction treatment clinics, and it brought it down to the emergency department and demonstrated that even without the longitudinal relationship, even with the brief contact that we have with these patients in the emergency department, we can begin them on a medication that works and that continues to work for the long term. So then our team in the emergency department at Mass General started looking at this. And we realized that there was actually three things that we were going to run into. But in order to figure out what those issues were, we broke down the problem. And the problem was, it was simple. The opioid epidemic was worsening in our emergency departments. Our treatment options were limited or ineffective, at least the ones we were using then currently. And buprenorphine was effective, but virtually no emergency departments provided it. And so we put a team together led by Dr. Alistair Martin, who at that point was one of our residents and is now one of our junior faculty members. And we decided that we were going to look at MGH emergency department initiated buprenorphine. This concept at that point was exceptionally novel. Dr. D'Onofrio's team at Yale has done it as part of a federally funded study. There were some emergency departments considering this on the West Coast. But in Massachusetts, it was novel, and it was one of the first programs in the country to consider doing this. We faced a few challenges. As I said, there were three main challenges that we realized we had. The first was the federal law, and I'll get into that in just a minute, looking at the requirements based on the Drug Addiction Treatment Act. The second was that we actually didn't have a protocol for buprenorphine. And the third was that even with a protocol, we realized that changing clinician practice would be hard. So we tackled these with initiatives. The first was that we made a Get Waivered campaign that Dr. Wakeman was kind enough to refer to. I'll talk more about that in just a second. But in this day and age of Twitter and hashtags, we realized we needed a brand. And so we built one, Get Waivered. We also developed one of the first ED buprenorphine protocols nationwide. And what it was a protocol to begin buprenorphine in the emergency department and seamlessly hand off care to the Bridge Clinic run by Dr. Wakeman and Dr. Kehoe on our addictions team here at Mass General. And then we wanted to focus on how we could actually improve clinician practice, and we looked at some behavioral economics techniques. Dr. Martin, the resident I mentioned earlier, also has a master's degree from the Kennedy School and the Kennedy School of Government and Public Policy. And one of the things that he learned while he was doing this was that a lot of the behavioral economics techniques used to get people to vote, to convince them that they should change their behavior and get out and vote and campaign, well, those could work in our emergency department as well to change our physicians' behavior. And so we started doing it. So the first step was to actually understand the federal law a little bit better. This federal law is old. It's almost 20 years old now. The Drug Addiction Treatment Act of 2000 requires that to prescribe buprenorphine, there is a specific training that physicians need to undergo to get a DEA X waiver. The training often costs money, though not always. It's an 8-hour course. And it's honestly an imposition for most physicians who don't do this as the major part of their practice. So after Dr. Wakeman invited me up to her office and she gave me this education, I got very excited. And I went out and I found an online course. I paid some money and I took the course and I submitted and got my DEA X waiver, which meant that in the entire MGH emergency department, we had one physician who was waivered to prescribe buprenorphine. What that meant, of course, is that while I might have had the training and the motivation, I had no idea how to actually do this. One physician can start change, but to make a system that allows for patients to come in and if they have opioid use disorder, seamlessly get treated 24 hours a day, 7 days a week, that's just impossible. And so we needed more physicians to get their waivers. So the first thing we did is we developed a Get Waivered campaign. And the goal was to nudge emergency physicians at Mass General to just get that waiver. And we figured we'd go from there. So at the start of the campaign, there was me. We recruited a team of designers, behavioral scientists, and public policy students. We designed and launched a campaign using design thinking, using that behavioral economics framework I mentioned earlier to motivate people to get their waivers. And our goal was to get a critical number of MGH emergency attendings to get waivered without making it mandatory. There's a lot of things that I make mandatory here, and everything from training in EPIC to filling out our credentialing paperwork. But making this mandatory was bound to backfire because nobody would use a mandatory training that they had to go through. So instead, we created a web page. We made the information necessary to get the waiver easy to access. You can still go to getwaivered.org and see this web page. We made sign-ups for classes easy. We made information about the PA-NP waiver for advanced practice providers easy. We allowed our clinicians, all of them, physicians, NPs, PAs, residents, to take action quickly and sign up for a class. It was a one-stop shop for how to get your DEA waiver. Dr. Wakeman came by, and she and Dr. Kehoe led a bunch of classes for our physicians. This is a picture of one of the first ones with Dr. Wakeman up in the front teaching a class of emergency physicians on how to get patients with opioid use disorder effectively treated with buprenorphine. We rewarded the physicians and the advanced practice providers who went through this training, not with money, but with recognition. This is Dr. Kehoe giving me a pin. We pinned this is our chair getting a pin. This is one of our clinical director getting a pin. We made sure that we made this something that they wanted to do, and we published and we publicized it broadly. After we had some success locally, we started getting more interest more broadly, and our local NPR station, WBUR, we were able to write an article published on their website about our practice. This started to get even more practice. We made even more traction. We made a Twitter page that started getting picked up. We mentioned this in faculty meeting. We mentioned success stories. Our physicians got excited about it. And then eventually at that point, 2 years ago, 40 out of 42 physicians had gotten their waivers without making it mandatory. We've hired a bunch more physicians, and now our fellows are also waivered. And so we have over 50 physicians. I think at last count it was 51 or 52 attendings. And there's one that doesn't have his waiver, but everybody else does. And that was without making things mandatory. The next steps were that we got some grant money, or we got some recognition from the NIH and NIDA. And on the right side of the screen, you can see Dr. Martin, the resident who led all this initiative. Based on this, we had folks reach out from Texas. And Get Waivered has become Get Waivered Texas, for Texans by Texans in Texas. It's expanded to Nebraska, where Get Waivered Nebraska is focusing on getting emergency physicians, primary care physicians, and others to get their Category X waiver. While hopefully the X waiver requirement will disappear over time, in the meantime, we're working on getting as many folks waivered as possible. The Get Waivered work continues, and you can go to our website to find more information. So please feel free to go to getwaivered.com/programs for more information. It's all free. And we're focusing now on getting our advanced practice providers who have more of a requirement. It's not 8 hours, it's 24 hours. We're focusing on them getting waivered as well. Our next challenge was that we didn't have a pre-existing buprenorphine protocol, so we put one together. We created the first seamless ED-initiated buprenorphine protocol. We created it with our pharmacists, with the Bridge Clinic run by Dr. Wakeman and Dr. Kehoe. We made sure that we publicized our practice. We wrote academic pieces in our major emergency medicine trade journals listed on the left. We created an easy-to-follow protocol that was applicable 24 hours a day, 7 days a week. And again, we made it easy to follow and then publicized it freely. The NPR, again, wrote a piece about this, talking about how we had a 24-hour, 7 days a week protocol, and that protocol is on their webpage, on the webpage of this NPR article, freely available for anybody to use all over the country. Since the program's launch back in 2018, we've initiated 100 patients on ED medication-assisted treatment, we were able to send 314 patients straight up to the Bridge Clinic without even needing to initiate them in the emergency department. And the vast majority of these patients are being followed up by the Bridge Clinic more long-term. Then, thanks to the Massachusetts Health and Hospital Association, the MHA, we were able to take our work and work with the state legislature to make this state law. The state of Massachusetts, the governor signed an act that now mandates that emergency departments be able to initiate patients on buprenorphine throughout the state, whether that's us here in Boston or small community hospitals out in the Berkshires. And we've been working together as a state through the MHA to create guidelines that allow this to be possible, whether it's referral to a Bridge Clinic like we have, or whether it's referral to other primary care clinics or other centers that allow for patients to continue to get follow-up. The fact that we were able to do this across the state is what's made this so powerful for us. It's not just one hospital doing this. It's an entire state full of emergency departments and hospitals doing it together. Finally, we're now focused on changing clinician practice because we've got a protocol. We've got emergency physicians who have waivers. Now we need to get them to use them. And so what we're doing is we're partnering with a behavioral economics nonprofit firm to come up with nudges that quickly create new practice patterns. Ideas 42 is a consulting firm that we partnered with. We got a grant from the Laura and John Arnold Foundation to help continue this work. So what we're focusing on now is we've mapped out the decision plan for how physicians decide to actually use their X waivers and treat patients with opioid use disorder. We've interviewed a number of physicians, advanced practice providers, and patients about what works and what doesn't work. We found that the protocol was easy, but it wasn't easy enough. We found that there was a lack of cues to initiate conversations. It wasn't top of mind. There was time pressure for physicians in the emergency department, much like there's time pressure for me to get through this presentation so we can take some questions. And it was unclear whose responsibility it was to actually initiate treatment. So we created some badge backers. We all have 1 million badge backers, but what we had on ours was, here's how you actually start the conversation. So on the right-hand side of the page, you can see that we actually gave tips on conversation starters, allowing our physicians to actually broach this potentially uncomfortable subject more easily. Our protocol was built into a QR code on the left, so anybody with a camera phone could just hover over the QR code and get the entire protocol pulled up. It wasn't top of mind, and so we started sending out reminders. I would send out these reminders to the entire emergency department, highlighting the great work that our clinicians were doing and calling out specific physicians who had been successful. We made it a little bit unclear clear whose responsibility it was. That badge backer says on the right, it says, I treat opioid use disorder, for patients who aren't quite sure if they can get help. We partnered with our EMR team to make the order set for buprenorphine ordering more easy to access. We wrote more articles about this, publicizing our work. And we continue to do our work with our Get Waivered campaign. If you want more information, please take your camera phone, point it here. You don't have to do anything else. The link will appear at the top of your phone. I want to acknowledge Dr. Alistair Martin, who's been instrumental in this and put together this slide set for us. And now, Dr. Wakeman and I would be happy to take any questions you have over the next 6 minutes.
Dr. Raja, thank you so very much. While we're waiting for the first question to come in on the chat box, and there it is, I just wanted to let people know that there is an additional resource available at aha.org/behavioral health. And that is, Sarah, Dr. Wakeman mentioned that words matter. 2 years ago, we did a video in conjunction with the American Academy of Addiction Psychiatry focused just on that. And the video features at that time and currently the CEO of Carilion Clinic speaking to her own peers, trying to change the culture. So one more resource to use. Here's the first question. How did you go about billing for the take-home med packs?
So Dr. Wakeman can feel free to jump in, but we currently don't actually bill for them. This is an initiative that we have started. We've received some grant money to help do it, and we currently don't have a mechanism for billing for the take-home med packs. Dr. Wakeman, anything else?
No, I think, the take-home packs, we sort of decided that for 2 doses, given the risk of patients not being able to actually fill the prescription, that it made most sense to give them in hand. But then obviously for prescriptions, people fill those at the pharmacy and it runs through their insurance.
So 2 related questions. I realize you had the slide with the QR code up, so I hope that the person asking for that was able to reference it. But another person asked if the slides will be shared. You can download the slide. I believe it is underneath resources. The name of the file is Wakeman-Raja, AHA. It's about 5 MB. And so, yes, you can download the slides right now. Next question, which includes the QR code. Next question, do you have any mandatory or suggested admission or triage questions to screening for OUD risk?
So in terms of screening, universal screening for substance use, both alcohol and drug use, is a best practice. The USPSTF recommends it for alcohol, and there's a current draft recommendation about universal drug use screening that is in draft form, but we'll see if it gets approved. For drug use, the simplest thing is to use the NIDA single-item screener, which asks in the past 12 months, have you used an illicit drug or a prescription drug for a non-medical reason? And then if people answer yes, that's a sensitive but not specific screening question, obviously, then you can trigger to a more specific screening tool, like, for example, the DAS-10 is what we use in our primary care practices. If what you mean is for risk of developing an opioid use disorder in someone who's being exposed to opioids, there are a number of tools that are used. The 2 that we use most commonly are the opioid risk tool or the SOAP.
Excellent, thank you. Another member participant asks, if you don't have a bridge clinic, do you have any recommendations on how you would ensure that patients can get a follow-up buprenorphine dose after their induction?
I would say, creating partnerships, particularly with primary care, so in the same way that if you're starting someone on, warfarin or an anticoagulant for a DVT, you're going to want to make sure that they're getting follow-up within a couple days with a primary care, that same model can work well for buprenorphine. We've done a lot of effort with our primary care docs to get them waivered to prescribe buprenorphine and comfortable caring for patients in the primary care practices, and so that sort of partnership can work really nicely where patients could be seen within a couple days for a post-UD visit in a primary care setting.
What metrics have you used to monitor implementation and provide feedback to the frontline staff? I know you noted a lot that you were doing the public.
Yeah, Ali, maybe you could speak to the kind of semi-real-time feedback you guys have given to your frontline staff.
Absolutely.
Go for it.
Sorry, go for it. So briefly, just because I know that we're running short on time, what we've done is we've given semi-real-time feedback, as Dr. Wakeman mentioned, letting frontline staff know about successes over the past week or month or so. But what we've also done is we have given feedback, say, 6 months down the line, sending staff feedback saying, hey, you know that patient you started 6 months ago, Jane Doe? Well, it turns out that she actually didn't just follow up in the Bridge Clinic, but she's been clean now for 6 months. And, Dr. Wakeman, I'm so sorry. Didn't use clean, but she's been in treatment now. I know. She's been in treatment for the past 6 months. Your work getting her into treatment for her opioid use disorder not only helped her that day or that week, but it's helped her for the past 6 months. Emergency physicians never see successful treatment work in patients, whether it's for their heart attacks or for their opioid use disorder. So giving our physicians feedback on their successes and saves has truly changed the game.
We are at the top of the hour, but so I'm going to ask a favor, Dr. Wakeman, Dr. Raja, do you have time for maybe another 5 minutes worth of questions, or do you need to go on to your...
Absolutely.
Okay. So a quick one is, I hope it's quick, in your ED, are you starting buprenorphine after naloxone rescue? aka of an overdose.
We are. And so not only are we starting it, but it's actually state law that in patients with, at least in Massachusetts, with an opioid overdose requiring naloxone, that they be offered treatment before they leave the emergency department, and that they have a substance use disorder evaluation performed. So we would be doing it anyway, but it's actually mandatory in our state.
So it was part of the state law that was passed?
It is.
Yes? Okay, great. Thank you. Do you utilize recovery coaches in the ED to support these patients?
We do, yep. We have an ED-based recovery coach who's actually shared between our emergency department and our bridge clinic intentionally to really be sort of the human glue that bridges those two worlds together and can meet people in the emergency room, connect with them, and then for those that come to bridge clinic can either continue to follow them there, but also can quite literally, accompany them to bridge clinic to get over that hurdle.
Excellent. Another question about monitoring the use of buprenorphine. How often are patients monitored, and how do you avoid addiction to this drug? And when I read that, I could hear you in my head saying, buprenorphine, they are not.
Yeah,
so anyway, please answer that more eloquently than I can. But
sure, no, that's great. I mean, I think it's so hard to unlearn these things because we have all been influenced so deeply by them. So people taking buprenorphine are physiologically dependent on it, just like a person, taking chronic opioids for pain or, taking insulin for diabetes. You need their medication to stay well, but they're not addicted, meaning they're not compulsively using it despite bad things happening to them. So I think that distinction between dependence and addiction is really, really crucial when you're trying to understand sort of treatment of opioid use disorder. In terms of monitoring, patients at the bridge clinic are seen quite frequently, in part because they, by definition, are not yet stable if they're coming to our bridge clinic. So, that can be every couple days. It's usually at least weekly, and as people get more stable and don't need that level of support, then we transition them on into community-based treatment, where when people are on long-term buprenorphine maintenance, they're seen monthly or sometimes even less frequently if they've been on for years and are doing very well.
Oops, sorry, I just read a question. I read a question. I was on mute. Was the dose that the patients took home fixed or variable based on their symptoms? And did you create your own patient education material, or do you have resources you would recommend?
So we give everyone enough to take up to 16 milligrams those first 2 days, which for most people is enough in that early induction period. But again, the dose pack is coupled with a referral to bridge clinic. So if they, are still having cravings or struggling, they could always come to bridge clinic that day or the very next day. We adapted our patient information materials from a paper that was published by Josh Lee and his colleagues at NYU that was published in the Journal of General Internal Medicine that compared doing a home induction where the patient starts himself on buprenorphine to an in-office induction and found no difference between those two. And they had some nice patient education materials as a part of that study, and we adapted those for the purposes of our take-home packs. And again, those are available via the NPR article. We're happy to share them.
That's right. Actually, Dr. Wakeman, I can forward them along to the team to put somehow on the webpage.
Sure. We will post that. And to answer another question, someone wanted to know if this was being recorded. It is. So we will have that posted along with any materials that Dr. Wakeman or Dr. Raja share with us, and we'll have it all at that site. Follow-up question to starting buprenorphine in the ED while the patient, when the patient overdosed and was provided Narcan. Do you start buprenorphine while the patient still has Narcan on board?
We generally don't. The half-life of Narcan is short enough that our practice is typically to let the Narcan run its course, and ideally then the patient can have this discussion with our team about starting buprenorphine.
And the last question, where can a hospital find guidance about establishing a bridge clinic?
So there's no real existing guidance yet. I think we've had a lot of people reach out to us for technical assistance and for questions, and we just published a piece in the Journal of Substance, the A word that I don't like, abuse treatment, about our Bridge Clinic, and plan to be publishing more about it. But we're very happy to share our model and hope to be able to disseminate it.
Excellent. Well, Dr. Wakeman, Dr. Raja, thank you for your, first of all, for your energy and your passion to move this very important treatment forward, to make it more available to patients at the right time and the right place, and to truly change lives. Thank you for your willingness to share this experience and inspire others to do the same. And on behalf of the AHA, thank you so much for your time and energies today. And with that, we conclude today's webinar.
Thank you, ladies and gentlemen.